So,
Right,
um,
right.
good evening, everybody. So, as gynecologists, we all are obviously seeing a lot of infertility even in our routine practices. So, poor ovarian reserve. Maybe lots of you would have seen, reports which come with very low AMH. Now, my talk would be to help you understand the basic of how to, kind of interpret or what all you need to kind of take into account to ultimately decide that, okay, this patient is a poor responder. Now, poor responders is a very heterogeneous group of patients, and there are no standard guidelines that are made for the management of these patients. Now, who all will you categorize as a poor ovarian responder? So, age is very, very important. Any patient who is, in the late 30s, 40s is definitely going to respond poorly to any stimulation protocol. If on top of that she also has an amenorrhea, which erratic periods happening after 4 to 6 months, that is another bad sign. AMH report, which is less than about 1.2, is like a predictor of poor ovarian response. In addition to that, if your FSH levels are elevated more than 25, so that again indicates a DOR, that is decreased ovarian reserve. And low testosterone, antral follicle count, which is less than 5, and sometimes you also look at the ovarian volume, which can be less than 3. So we kind of come to a conclusion that, okay, we are dealing with a patient who's a poor ovarian reserve. So we know a woman's biological clock does tick after 30, and that really cannot be taken lightly. So as clinicians, our role is to assist patients who come to us in that age group, that we don't really delay the right kind of treatment for them. So they should not unnecessarily be spooked up about bad prognosis, and that all of them don't really need to go for IVF. But definitely we need to understand as to what subcategory of patients needs what kind of management. So in 2011, Bologna-Escherick criteria for poor responders was made, and this said that there has to be two criteria out of the three features which should be present so that we can declare a patient to be a poor responder. Either the patient should be of an advanced maternal age, more than 40 years. A previous stimulation protocol should have resulted in less than 3 or about 3 oocytes being retrieved with a conventional stimulation protocol. And any marker of a poor ovarian reserve, wherein her antral follicle count is less than 5, or her AMH is about 1.1, 1.2. More practical or more relevant is the Poseidon criteria, wherein our population of poor responders can be broken up into 4 categories. Poseidon group 1 and 2 basically deals with that subset of patients who have AMH more than 1.2 nanogram per ml and an antral follicle count of more than 5. But group 1 is a younger age group, less than 35. Group 2 is the age group which is more than or equal to 35. And group 3 and 4 is that set of patients where the AMH is low, less than 1.2, AFC is low, less than 5. Again, the difference being in 3 and 4 is 3 is the younger age group and 4 is the more than 35 age group. Now, when a patient comes to us in our clinics, now what all do we look at? The age is very, very important. So if it is a younger patient with a lower AMH, she will have a better prognosis. Whereas older patient with obviously a lower AMH is a, not as good a prognosis. So age is a very big determinant of the ovarian response to stimulation. We all know that as a woman ages, her oocytes they keep getting depleted. So when she is the intrauterine life, 5 months is when the maximum number of oocytes are present, and this declines. By the age of 30, falls down to as much as 12%, and by the time a woman is 40 years of age, as low as 3%. So definitely the biological clock does tick. So age is important. Then next, now once you have assessed, okay, and you've also taken a history, probably you have to rule out that, okay, you are this age, and you have to also look at her BMI. You have to rule out that she doesn't have bad habits, like she's not a smoker, she's not a, she doesn't take a lot of alcohol, because all this also impacts her ovarian reserve. Then you have to, make sure she doesn't have any other systemic illnesses. So that, of course, is the clinical part, which we, while we are eliciting the history or we are talking with our patients, we kind of come to a certain conclusion by way of the clinical judgment there itself. Where when you send your lab parameters, what all is important? AMH is very, very important, and all of us and many of us do write it. Now, what is AMH? Anti-Mullerian hormone. It is a dimeric glycoprotein which is produced by the ovaries. And in the ovaries, it is only the preantral and the antral follicles which produce this AMH. And this AMH can be tested at any time during the cycle, actually. It is not going to give you variant results. But still, because along with AMH, we will also order other tests. So like, let's say FSH, or we'll also want to see the antral follicle count by way of the TVS. So we usually kind of write all of this on the second or the third day of a period. But as I said, it's not mandatory that you do so. If a patient comes to you maybe later in the menstrual cycle, you can still order an AMH for her. So AMH is a very good quantitative reflection of the ovarian reserve. However, it cannot predict the amount of genetic damage that will be there in the oocyte and consequently the embryo. And there is a certain range we have defined so that we can, categorize our responders. So a patient who has a AMH of 4 to 6.8 roughly will be a normal responder. Who has a value more than 6.8 will be a high responder, PCOD patient. Low responders will be like 0.3 to 2.2 nanogram, and very low. So, and I would like to tell you that the fluctuation will be more for a younger patient, will not be as much for a older patient. Now, there will be certain factors which can, kind of bring about a variability in the AMH. Age as one, we've already spoken about it. If there is use of hormonal contraceptive pills, that also, if like, let's say 5 to 9 weeks of usage of the oral contraceptive will also impact the AMH value. Smoking, definitely, it will kind of lower your AMH. Ethnicity, there is a reduction in the melanodermic patients, 22% less than the Caucasians. And then use of gonadotropins and GnRH agonists will also have an impact. Now, serum AMH levels, they definitely correlate, like when we start our patients on stimulation. So the AMH, if let's say it's a patient with a low AMH, so what will be the outcome of our stimulation? Will definitely a patient undergoing, ovarian stimulation and the AMH is low, we should already have a mental picture that she is probably going to require more gonadotropins versus a patient who's a normal responder. And the number of oocytes that you will retrieve, the number of mature oocytes and the ones that will finally fertilize will also be correlated with the AMH level. A patient with low MH, lesser number of oocytes are to be likely to be retrieved, lesser number will be fertilized. Similarly, if it is a PCOD patient with a higher AMH, you will retrieve more number of oocytes and consequently will be able to have more fertilized oocytes, more embryos. So therein the correlation definitely is there. Now, third very important thing that is important now is antral follicle count. AMH and antral follicle count. If we take these two criteria, they've got a very good predictive response for telling us the response of that patient to ovarian stimulation. So these two criteria are highly predictive of the likely response that the patient is going to give. So what is AFC? It is basically when we, on a second or the third day of the period, we'll call our patient. We'll make her, undergo a transvaginal ultrasound. We will look at the follicles in her ovaries, either sides. So the follicles which are around 2 to 10 mm, we are going to measure them in both the ovaries. Okay, so this is called the antral follicle count. And this also definitely will show age-related decline. And there is a very good intracycle reliability of AFC if done by experienced gynecologists and radiologists. And even this, helps us predict the response to stimulation. How? If let's say a patient has got about 8 to 10 follicles, both sides, she falls in the category of a normal responder. less than about 5 follicles each side, she's likely to give a poor response. And anything like more than 14 and all, she's going to be a hyper responder. So this is how the AFC is going to guide us into categorizing our response to stimulation protocols. Then in addition to this, on the second day, we would also like to, for a baseline, when we are investigating a patient, we should also look at the FSH and day 2 estradiol. So any patient who is a decreased ovarian reserve patient will obviously have a elevated FSH level. And elevated E2, normally around day 2, the E2 level should be like 60 to 80 picogram per ml. But if you have a higher level, there is a likelihood that there is the decreased ovarian reserve or the ovarian aging has probably caused the inappropriate advancement of follicular development. So androgen levels we don't do on a routine level, but can be done in cases where we're expecting a poor ovarian reserve. Inhibin B not done routinely. So how do we manage our poor responders? Once we have kind of elicited from the history, we've got our lab reports and we are okay, we've made a decision, okay, she is a poor responder. So how are we going to manage them? Now, management, definitely, like for any infertility patient, any patient that you kind of are counseling for a IVF or whatever for infertility treatment, you have to focus on their they're managing or reducing their stress levels by way of lifestyle modification. You have to counsel them on intake of a good diet, which is rich in vegetables, fruits, rich in antioxidants, nuts. And they should cut down on their smoking, alcohol intake, or any substance abuse that they probably were doing, because all this is definitely going to impact how they respond to our stimulation. Now, this being said, the general measures, now there are certain adjuvants also which will help the poor responders, namely growth hormone, androgens, antioxidants, L-arginine. Some of them have shown to have a proven role. Others are controversial and not, known to show a response. So growth hormone. What does the growth hormone do? It enhances the response of the granulosa cells to the gonadotropins. There is local increase of insulin growth factor 1. This in turn modulates the action of FSH on the granulosa cells and improves steroidogenesis. Also, LH receptor formation is induced, and this augments your aromatase activity. How do you use it? You give a dose of about 8 to 12 international units on the second or the third day of the menstrual cycle, along with the gonadotropins till you give the trigger. Then androgen supplementation also helps. So what you can do is that either you can give a transdermal testosterone, or you can give these patients DHEA. Transdermal testosterone by way of a gel, 10 to 12 milligram per day, which you start in the previous cycle, about day 15, give it for 2 to 3 weeks. And how does it help? It increases the intra-ovarian androgen concentration. And pre-treatment, they say, is associated with decreased duration and total dose of gonadotropins required, increased number of COCs retrieved, increases the clinical pregnancy rate by 15%, live birth by 11%, and poor responders. And DHEA is another thing that many of us do right for poor responders. This is given as a tablet, a 75 milligram per day, and you usually start at about 6 to 8 weeks prior to, starting any kind of stimulation protocol for these patients. And they have shown to raise the IGF-1 concentration. Now, other things that you may use as adjuvants can be estradiol in the luteal phase of the previous cycle. This tends to improve the synchronization of the follicular pool that is available. L-arginine has shown to have helped. Antioxidants can be started 2 to 3 months prior to, IVF or any kind of, IUI, if you want to attempt that for these patients. Aspirin and pyridostigmine have not really proven any role. Now, there are lots of stimulation protocols that we have available for poor responders. People who are into IVF, into infertility, will probably be able to make some sense of these protocols. For the others, this may sound a little confusing, but There are a few which will be preferred more than the others and are like more routinely used by the infertility units. And the first one, that is GnRH agonist long protocol. This is one of the favorites for poor responders. What you do is that in the previous cycle, you will start them on a GnRH agonist, 500 micrograms. And then you subsequently reduce the dose to half once the gonadotropins are started. Now, this they say results in lower cancellation rates, increased number of oocytes retrieved, better quality of embryos. Then there is another protocol called the GnRH agonist stop protocol, as the name is suggestive. So you stop the GnRH agonist. So when you stop it, only then you start the gonadotropins. This offered no further real advantage over the standard long protocol. Then you have the short protocol or the flare protocol. Here, the gonadotropins are started 2 to 3 days after you have started your GnRH agonist. So you start the GnRH agonist, give it for 2 to 3 days, and then you start your gonadotropin. So this gives you an initial flare of the gonadotropin secretion. Though there are conflicting results in literature, due to premature rise in LH and progesterone in the follicular phase. So again, not really too much in favor. Ultra short GnRH agonist protocol. Here in the previous cycle, you are using oral contraceptive pills or estradiol about from day 12 to day 21. Then your agonist is started on the first day of periods, dose of 500 micrograms, and on the day 4 you start the gonadotropins, and the dose will be a little high because we are dealing with poor responders, so it will be 300 to 450 IU. And then when the follicle reaches 14 you're going to add the antag so that we don't have a premature LH surge. So this is the ultra short protocol. Then you have a microdose protocol. In this again, you are using oral contraceptives in the previous cycle. Then from the day that you stop the oral contraceptive, from the third day that you stop the oral contraceptive, you're going to start your GnRH agonist in the dose of 40 micrograms twice a day. And from the fifth day of stopping your OC pills, you will start on the gonadotropin, 300 to 450 international units. Now the very favorite protocols that most of us use in IVF these days is your GnRH antagonist protocol. And this is again very useful even for poor responders. So just like we will start them on, the gonadotropin starting second or the third day. And once our lead follicle is around 14 we will start them on antag. And then, once the trigger is given, we will plan our ovum pickup. So this one, what is the advantage here is that definitely it prevents your premature LH surge. The stimulation protocol is shorter, lesser amount of gonadotropins is required. It is also pocket friendly because lesser number of drugs are being used. Now, another entity we must talk of here is, like, these were all now the 4-5 protocols that I told you about, but the commonly used ones are the GnRH long agonist protocol and even the GnRH antagonist protocol. They're equally in favor, or equally, like, you can say that they give comparable results. So this is the gist of all these. You can just remember these two. Then about the natural cycle that I was explaining to you. As the name suggests, we are just going to spontaneously follow the lead follicle, and then we will carry out IVF with that single follicle. This will not use any medication whatsoever, but there is a modified natural cycle IVF, wherein we are going to use minimal amount of exogenous drugs. Like maybe we are giving a HCG for trigger so that the oocyte is mature enough before we do a pickup. Or else to prevent a premature LH surge, we will add your antag. So all these then become a modified natural cycle IVF. And what category do we use this? not that we use it for all poor responders. You're most likely to use it in a younger subset of patients, and the ones who are refractory to controlled ovarian stimulation, and ones who decline, that they do not want a donor oocyte. So, and it is supposed to be giving you a good implantation rate also, vis-a-vis slowing, COS in these patients. So this is another option that we can think of. Now, recombinant LH. Recombinant LH is, supposed to increase your, clinical pregnancy rate. There's a recent meta-analysis in Fertile Sterile 2012, which showed a higher implantation rate and clinical pregnancy rate in the RH supplemented group compared to FSH alone. So again, there are studies going on, but no conclusive evidence on the use of RLH. It's kind of increases the cost. So maybe instead of RLH, when we use HMG, which has a component of LH, so that is more cost effective. And another methodology that can be used is dual stimulation. Now, this is based on the fact that within the same menstrual cycle, you can have a multiple wave of recruiting your follicles. So you in fact carry out a pickup twice in the same menstrual cycle. And as I have shown you in this diagram, so we have started the cycle, used a combination of FSH, LH, added the antag, then a pickup is done, and then you give a gap of about 3 to 4 days, 2 to 3 or 4 days, and then again you start a stimulation, add antag, trigger, and do a pickup. So within the same menstrual cycle, you're doing a pickup twice. So you are enhancing your chances of retrieving more oocytes because it's already a poor responder. You're not expecting lots of oocytes. So you're trying to, do it twice and get more number of oocytes. Now, also they say that rather than, doing a day 3 or a day 5 transfer in these patients, you can attempt a day 2. Because what happens is that if we leave our embryos for longer in the lab, the culture conditions can probably, our oocytes might degenerate, or they may not, they may be an arrest of growth. So in such patients, if we shorten the duration of embryo culture, and we will probably end up getting more embryos to transfer. So rather than taking them to day 3 or day 5, we can do a day 2 transfer, so that we have more number of embryos to transfer, and thereby probably increasing the pregnancy rate. And another thing we can try with poor responders is that we can, over various cycles, we can retrieve their oocytes, or their embryos created can be vitrified. So we can accumulate them, and the strategy is to improve pregnancy rate in these poor responders. So over several stimulation cycles, they fertilize them, and this gives a higher live birth rate per patient treated, and also the dropout rate will be less. And last but not the least, you can offer donor oocytes to a patient, but lots of patients may be willing for this, and we definitely, because we choose young donors, chances of having a good embryos is definitely higher, and we end up getting pregnancies with donor oocytes. Another thing, which is obviously with the PGS being there, PGTA, they say that you can probably do that, because a poor responder will most likely to have an aneuploid embryo. So rather, if we offer them PGS, we can kind of ascertain that we are choosing a euploid embryo, and thereby we can increase the chances of a successful pregnancy. So now, this said, I do not know how much really the audience would have kind of understood, but I would like to just explain to you by way of a few of my clinical cases, which I have not really, put down as my slides here. But I would like to tell you now that when we see a patient, it is we should not push all our patients into, thinking that they need an IVF. A patient who's a poor responder may end up conceiving on their own also. Like for instance, I had a patient who was a 26-year-old, married for 1 year, okay, but her trial time was only about 4 months. So here we are dealing with a patient who is young. AMH was zero point 0.8, so zero point 0.8 is less, but her trial time was less. So in such patients, point is the AMH is not a measure of a fecundability. She has to try for a good enough amount of time before we really declare it to be an alarm, and before we ask her to proceed on to the next steps of, being helped with maybe an IUI or maybe an IVF. So this patient, I counseled her to kind of keep trying. I gave her a DHA preparation and some antioxidants, and counseled them about, trying in the fertile period. Though of course she had been scared by some people that she needs an IVF and there is no other way out. And as you would have it, she was lucky. She conceived on her own, and right now she's 5 months plus. So take home point here is that if the patient is young, even though the AMH is less, she should be given enough trial time before the alarm bell is rung. Similarly, I will also quote another example of my case. A 33-year-old would been married like 1 year, but again, she had not tried enough. So she was actually, again, her AMH was 1.1 or 1.2. And she was also again was suggested that she should go in for IVF, and that it doesn't really augur too well for her to be trying otherwise. So again, because the trial time was less, though the age was more, and the AMH was not very bad. 1.1 or 1.2 is not very bad. So here again, we can ask our patient to try. Okay. So let's say maybe, if she can probably, she should not be waiting for very long though, that, she's like waiting for a year, or maybe, our threshold for getting into more stringent measures for her will be probably allow her to just, try for 4 to 6 months with either, maybe just 2 cycles of ovulation induction, then she can move on to IUI. So point is that depending upon the age, as I said, the AMH, and obviously you will correlate the AMH with the AFC, because that is like gives you a much better idea as to what is our ovarian reserve. Sometimes the AMH can be, a little, there can be a fallacy, or they can give you a false picture. If another thing is that I would like to, which I probably did not mention earlier, that you should always ensure that your patients get the MH done from a good lab. Now that is very important, because the AMH, the better labs, they do it with the automated methods, and their results are more reliable. But whatever said and done, you should not just send it to any lab, because therein the difference happens. So to ensure that you get a good enough report, you should send it to a good lab. And another thing that I like, let's say, you can also have a very, very, confusing picture sometimes. Now, not necessarily that every low AMH will only be a poor responder. Sometimes a normal AMH patient or a normal AFC patient can also be a poor responder. So again, I'm quoting another of my patients. She happened to be a 34-year-old, married for 4 years, but she had no intent of actually planning a conception. She's like a hardcore professional, and she didn't really want to, have a pregnancy as of yet. But she wanted to, have an IVF and probably cryopreserve her embryos. That was what she had planned. And she underwent a stimulation cycle at a very well-known center in Bombay, wherein they tried a stimulation protocol, and after like 6-7 days, they finally had to abandon, because they could not, you know um, they could not go beyond probably some 3 to 4 follicles, and so they abandoned the cycle. Now, when she came to me and we looked at her case, we realized that the AMH was around 6. The antral follicle count gave a polycystic picture. And but why did she, respond like this? Now that is actually very unexpected. You will not expect a PCOD patient to respond like this to stimulation. So she, according to the Poseidon criteria that we spoke of earlier, she falls in the category of group 3, wherein, I'm sorry, she falls in the category of, group 1, wherein the AMH is good, the AFC is good, and the age is also actually less than 35. But why the poor response? So then we kind of looked into her other reports. The LH was on the lower side, the testosterone was on the lower side. So the other things that we tried with her was that we gave her a testosterone gel before we started her stimulation for about 2 weeks. And also when we started her stimulation protocol, we started with 150 FSH and 75 of HMG minopor, and then gradually increase the HMG component. And we were finally able to retrieve about 9 oocytes for her, of which 7 were M2 and 2 were like an M1. And what I'm trying to drive home the point is that we can have a very, very varied picture, and not that all patients with a low MH or a low FC will only behave as poor responders. So we have to actually, kind of make sure that we do a very clinically thorough uh, assessment of our patients, from the history to their lab parameters to any previous stimulation protocol that would have been tried for them. So this all helps us to guide us into formulating the stimulation protocol in the subsequent cycles for our patients. So I guess that's all that I have for you. Thank you. So now if there would be any questions for me.
Thank you, ma'am. Thank you very much. Especially the cases which you shared at the end of your session were very interesting. So thank you very much for that nice talk. We would be waiting for the questions, and whenever questions are there in the chat box, I will read out to you, and
Yeah.
I'm waiting for that. Ma'am, to begin with poor responders, do you always give any adjuvant treatment, or straight away you go to
No,
stimulation?
I never rush up my patients. It is very important that you kind of work up your patient very gradually. One thing is that you should always counsel your patient very well. So counseling is like preparing them for this journey, which they have to be very patient about the response that they get to treatment. And let's say if the patient is also like, if there is a higher BMI, you also have to kind of tell the patients, motivate them to lose weight, because losing even 5% of the body weight really increases their chances of achieving a good pregnancy. So right from there to improving their diet, incorporating fruits, veggies, I start them on antioxidants. And as I said, a poor responder, start them on DHE if you already know that they have a low AMH. So that you can, like, the DHA can be started 6 to 8 weeks prior to start of any kind of treatment. If you are planning an IUI, even before that you should. It's not that you straight away jump the gun and take them on to treatment the very cycle that they come to. No.
Right, ma'am. Thank you. Ma'am, there is one question from Dr. Ratna Sharma, and the question is, if the patient's AMH is more than 15 or 16, then what is the fate of this patient? How to manage?
15, 16 definitely happens to be a PCOD patient.
PCOD.
So PCOD again, like as I have told you, even otherwise, you have to start counseling from the very basic of lifestyle modification. You have to tell a PCOD patient that weight loss is extremely mandatory for them to have a good response in this stimulation cycle. So start from there. Again, add them some adjuvants like myoinositol preparations. If you think that probably they were given some kind of a stimulation previously with let's say clomiphene or letrozole or something, and they fail to even ovulate then, so maybe adding metformin can also be a good choice there. And other than that, yes, in these patients are also likely to hyper respond because the MH is so high. So adding metformin, and when you are starting them on any stimulation protocol, and letrozole is the preferred drug of choice for any patient who's a PCOD patient. So that's the current recommendation for. And then when you're probably planning an IUI for them, even then you have to be very careful that they don't hyper respond. You don't want to handle OHSS for a procedure as small as IU. Even, I mean, right now we talk of, zero OHSS happening even in IVF. So there is just no scope that, you mishandle your patient. So therein PCOD patients have to be very, very carefully stimulated. There has to be a very delicate balance of, just trying to make some 2 or 3 follicles and not really, going beyond and, landing ourselves in a soup.
Right, ma'am. Thank you very much. Ma'am, considering the topic was poor ovarian response, ma'am, is there any inclination to use antagonist protocol versus agonist protocol? I mean, within the pure per the subset, any
See,
preferences?
as I just told you, there are studies which are for favor of the GnRH long protocol, whereas there are also studies which say that the anti protocol is just as good. So I guess it all depends as to how each clinician or each IVF unit probably has their own experiences. But as far as the literature goes, an antag is equally good. In fact, as I had mentioned, it is cheaper because ultimately the cycle length is less, the amount of drugs being used is less. So definitely, and you're also preventing any kind of premature LH surge. So antag is actually preferred even in poor responders in the current scenario in today's times.
Yes, ma'am. Thank you very much. We are still waiting for additional questions. Ma'am, apart from your presentations, if you would add to give any few tips or something like that, would be very useful.
Tips is basically, I mean, I would just like all people who are here. I don't know if people are into IVF, they would obviously know more and would understand more. But as a general gynae practitioner, as I said, AMH always should be done from a good lab. Very, very important. Okay. And also, it cannot be the only criteria for you to come to a conclusion. Please also make sure that on the second day that the patient, with the baseline investigation that you start with for an infertile patient, it should be day 2 or day 3 of her AMH, AFC, and FSH. Okay, so these three will actually give you a complete picture of, her ovarian response or her ovarian reserve. So this is something that you should be careful about, and the age is equally important. As I said, if it's a young patient with a low MH, is is far better than obviously a older patient with a even maybe a better AMH. So the age again is very important.
So, ma'am, probably low MH, but young patient, there are a possibility that she will give better results than old with.
Absolutely. They also, as I said, there's this patient who was zero point 0.8 nanogram per ml was the image. She conceived spontaneously.
Yes.
So
Yeah.
point is you have to give them enough time and not jump the gun or scare them and push them towards IVF or stuff. Don't have to do that. So each case has to be handled on a case to case basis.
Yes, ma'am. Thank you very much, ma'am.
Thank you.
Ma'am, I don't see any additional questions in the chat box. So thank you very much for your time and for that excellent
Yeah. Thank you
presentation,
so much. Thank you. Thank you.
especially for those 3 cases you shared with us. So thank you for your support, and it was an excellent presentation.
Thank
Thank
you.
you very much. Heartfelt thank you from Shield.
Good night. Good night. Bye. Thank you, everybody. Bye bye.
Thank you. There is a comment from Dr. Radha Madhvi that the presentation was excellent. So
Thank you so much. Thank you. I thank the Shield Connect team for this, opportunity that we could connect like this. Thank you so much, all of you, for all your support. Thank you.
thank you, ma'am.
Bye bye.
Bye bye.